Thank you. Can you hear me clearly in the back? Okay. So as before, a couple of ground rules. I'll never talk for more than 50 minutes without a break. If you have any questions, please let me know. That goes for the people who are attending remotely. I'll try to keep an eye on that as well. And then you've got an outline on one side of that page and then an evaluation on the back side. And we definitely want your feedback on this. Just leave the evaluation on the back table when we're done. So we're going to talk about infectious diseases, and the way that I would frame this is that this is not just about taking care of your patients, but this is about taking care of you. For all of us, our most important job is to go home safely to the family every night. And so as we go through this, I want you to think of questions that you have, think of cases that have come up, and think about how we can do our job as safely as possible, particularly as we get into the biggest and busiest season for infectious disease. So we're going to start off with some basic background information about the different kinds of microorganisms. So we are surrounded by bugs. There are bugs on our skin. There are bugs in our intestine. When we take lots of antibiotics and we kill off the bugs in our intestine, that can be a problem. So there are the normal flora that live around us, and then there are pathogens. And these can be the normal flora that, when they begin to cause disease, are then pathogens. That can be Staphylococci, Streptococci, Enterobacter. So staph and strep are common bugs that live on the skin. Enterobacter more often lives in the intestine. You can have viruses, rickettsia, and then you have opportunistic pathogens that affect people who are immunosuppressed. And so the normal flora are more likely to cause significant problems in people who are immunosuppressed. So the most common thing we deal with is bacteria. So some common bacterial diseases that we see are sinusitis, otitis media. Now, those are two things that we think there's a bacteria associated with that. We also know now that antibiotics aren't quite as helpful as we used to think they were. And so the guidelines for prescribing antibiotics for sinusitis and otitis media have definitely been walked back over the last few years. Bacterial pneumonia is definitely something we deal with in the pre-hospital setting. Unfortunately, we do also deal with pharyngitis in the pre-hospital setting. Tuberculosis is a bacterial infection, and we'll talk more about that. And then chances are you probably saw someone with a UTI, if not already today, at least on your last shift. So let's talk about how bacteria grow. There is a lag phase where there is slow growth. That's this flat portion of the curve. And then once they get used to the food and nutrients in this habitat, then they start having exponential growth. So this curve shoots up, and then they're very successful, and then they start typically to compete for small, dwindling number of nutrients. That's the flat part. And then they often build up toxic waste products, and then the bugs begin to die. So that's the natural course of how bacteria grow. And you see this in your patients who are having bacterial infection. They may feel, feel a little icky, and then all of a sudden, the classic one is like a strep pneumonia. They just feel awful as the bacteria expand exponentially. This is often one of the things clinically that most often predicts this phase, where people have bacteremia, or an overwhelming amount of bacteria in their blood, or shaking chills. You've probably seen someone who has rigors or shit, not like, oh, I'm a little chilly, like their whole body is shaking. And that's this peak phase of bacterial growth. Just a little bit more background around bacteria. So we talk about bacteria in terms of how they take up a gram stain. This was something that Dr. Graham came up with. And you'll hear people talk, oh, this person had gram-negative sepsis, or this person has a gram-positive infection. A rule of thumb is that gram-negative stuff is below the diaphragm. And then gram-positive stuff is the stuff that's above the diaphragm and on the skin. That's a rule of thumb. Obviously, if you've got something that's on the skin right near the rectum, you can mix those things up. And then we also classify the bacteria just by their shape. So people might say this person has gram-positive cocci. That means that there are bacteria that take up the gram stain and they're shaped like a ball. So rods are more often gram-negative, so the most common one that we deal with is E. coli. E. coli is a gram-negative rod that lives in the intestines, and then they can be shaped like spirals. And the classic example of that is syphilis. Thankfully, not as common as it used to be. And then bacteria cause bad effects not just because of what they do themselves, but also what they release. So gram-negative bacteria release an endotoxin, something from inside the cell, during that cell death phase, and that's highly toxic. So the person who has a UTI and then crashes and burns all of a sudden becomes extremely hypotensive, very difficult to resuscitate. That's most often because the bacteria are then dying and then releasing this endotoxin. Exotoxins are the toxins that are released by a living bacteria. So the one common example of this is staphylococcal scalded skin syndrome, or SSSS. And so these are patients who have some kind of staphylococcal infection. This can come from something like toxic shock syndrome, or it can come from a skin infection. And the living bacteria produce this exotoxin, and that can make people extraordinarily sick. Clinically, this looks like someone who's got really red, really flushed skin, and is really hypotensive. So viruses are obligate intracellular parasites. They cannot make their own energy. They can only live within cells. So all their growth, all their reproduction is within the host cell. Now, viruses also can go through very rapid replication. And so anyone who's ever had the flu or had a cold that really came on quickly knows that feeling. Whereas bacterial illness tends to be focused most often in one part of the body. So either you have a pneumonia or you have a UTI. Viral infection goes all throughout the body. And so the people who are saying, well, I'm throwing up, I have diarrhea, all my muscles ache, I've got a headache, my hair hurts, those are people who most often have a viral infection because it affects all of the body at the same time. Now, this can be difficult to differentiate from bacteremia because that's a disseminated bacterial infection, but much more often people with a viral syndrome have symptoms all over their body, whereas bacterial infection is localized to one part of the body. So there are other microorganisms that are less of an issue for us, but still do come up. So prions are small particles that are normally in the central nervous system and can cause the disease. What are some examples of prion diseases? Mad cow disease. And what's something that we have here? Yeah, chronic wasting disease in elk. And so this has been described generally as long as you avoid eating stuff from the central nervous system of your elk, you'll be fine. Fungi are things that affect all of us. That's athlete's foot, jock itch, but particularly in immunosuppressed people, fungi can cause bad invasive infections. One example is mucormycosis in a diabetic, where they get an invasive fungal infection in their nose. And so what might be look like a typical sinusitis on the outside, we have to take much more seriously in someone who is immunosuppressed and especially diabetic. And then there are parasites. So these are something that are more common in the developing world, but we still deal with here. This is Giardia lamblia, what causes beaver fever. And so that's typically a foamy, profuse diarrhea. Entamoeba histolytica cause liver cysts. The helminths, the worms, so something that we definitely do deal with here are pinworms. That's most often like really intense anal itching in school-age kids, and occasionally a school will have an outbreak of that. Hookworms and trichinosis are less of an issue here. One protozoan disease we do see here is cysticercosis. So the pork tapeworm can, if you're eating undercooked pork, especially if that pork is living someplace where it can get in contact with human feces, it can form little cysts in the brain. So it's a common cause of seizures in immigrants from Latin America, who are especially people who are coming from more rural areas. And it's not uncommon to see someone who has a first-time seizure in their 30s or 40s. You CAT scan their head, and they've got these little circles in there from the tapeworm making cysts in their head. And then we've obviously got ectoparasites like lice that don't get inside the body but just infest the outside of the body, and unfortunately the ambulance sometimes. Okay. So now we're going to move on to talk about how diseases spread. Any questions about the last section? I'm just going to check. Okay. Yeah. This sounds off. How about that? Okay. So the transmission of infectious disease is an interaction between the host, the infectious agent, and the environment. So we've already talked a couple of times about how immunosuppressed people are more likely to get infectious disease. The infectious agent can vary, for example, what strain of the flu we're dealing with, and then the environment. So there's some bugs that thrive more in dark climates, in warm climates. It affects what reservoirs the disease has. So for example, influenza is where we often get new strains of influenza is from Southeast Asia, because you have people who farm both pigs and ducks. And so there's swine flu and there's bird flu, and they have a chance to mix and come up with new kinds of influenza. And then you can have direct transmission or indirect transmission of an infectious agent. So obviously one of the routes of exposure we're most concerned about is bloodborne. We'll talk a little bit more about specific bloodborne diseases. We're also obviously concerned about airborne transmission. Sexually transmitted diseases have never gone out of style, and still are an issue, and are becoming more of an issue because we're getting more drug-resistant sexually transmitted diseases. Fecal-oral transmission, I think, is best described as a surprisingly effective way to spread disease, and still is, and we'll talk about diseases that are spread like that. And then there are foodborne diseases. And you can talk about the theoretical risk of infection, meaning how might this affect you, versus what can you measure, how many people are actually getting sick from this infectious agent. Other things that affect, we talked a little bit about mode of entry. What does virulence mean? I heard how strong its ability is. Right. So virulence, so there are some, so take for example Ebola. Ebola is extraordinarily virulent. It has kills about 90% of the people that it infects. That makes it harder to transmit because people don't walk around carrying the disease for a long time. They die fairly quickly. So very virulent diseases are typically not as transmissible. When we get into problems is where you have something that's fairly easily transmitted, like a pandemic flu or like SARS, that's also fairly virulent. So the number of organisms transmitted, so that can, the difference between a needle stick where you have maybe a hollow point needle, say that a surgeon was sewing with, a solid point needle that a surgeon was sewing with, is not going to carry as many organisms as a hollow point needle that you were using to draw blood and that carries a lot of blood that has that organism in it. Different people have different levels of resistance to certain diseases. For example, there's some people who have been found to be at extraordinarily low risk for getting HIV. And then there are other host factors like general immunosuppression that affect how likely someone is to get infected. The infectious process goes through different phases. So there's a latent period where you're infected, but you don't have signs yet. You're not transmitting the disease yet. Often that then comes into a communicable period, sometimes even before you have a lot of symptoms. So pertussis, for example, is something like before you really get into the painful paroxysms of cough, a whooping cough that lasts for a long time, you're communicating the disease. Then there's an incubation period, and then there's the period where you're sick. So take the common cold. There may be a time where you're around some other people who have the cold. You see, you rarely get sick at the same time as other people in your family. Then there's a period where you're starting to have runny nose or sore throat, and you're communicating it. And then there's this incubation period where you may not feel too bad for a little while, and then the disease period. Okay. So now we're going to move on to talking about the body's defenses. So we have natural defenses, intact skin, and the respiratory system naturally filter disease. And then we get into the specialized defenses that the body has. And the reticuloendothelial system is what identifies foreign material and then triggers an inflammatory response to that for the things that get by the initial barriers. The leukocytes, or your white blood cells, are part of that initial defense. And then you can have cell-mediated immunity or humoral immunity. And so the important association to make is that humoral immunity is what results in the formation of antibodies. So this allows you to have memory for a certain infection and for the body to specifically target that infection. Antibodies are also called immunoglobulins. You'll hear people talk about IgG, IgM, IgA, IgE. The specifics of that are less important to know than knowing that's what triggers your body's response. The one we deal with most in EMS is IgE. What's a pathology that we often see that involves IgE? Anaphylaxis. So IgE is your rapid response. And so autoimmune diseases also involve these immunoglobulins. So another way of looking at the immune system is to look at how it fights infection. So the complement system is basically a way of amplifying the signal that you get from that antibody to ramp up the fight against disease. So for example, it can recognize some of the endotoxins and then start to attack those. The lymphatic system includes the spleen, the thymus, lymph nodes, ducts, and that's where the white blood cells will do a lot of the attacking of bacteria, the phagocytosis, where they're eating the great song. And so that's where that happens. So what patients do you see that have, what are patients who have impaired function of the spleen? HIV? Who else? So obviously you'll see kids, for example, who were in an accident and got a splenectomy. That's part of the reason that the surgeons do a lot fewer splenectomies on kids than they used to. But kids who don't have a spleen, or adults who lost their spleen as kids, have less of that. Patients that we see less frequently here, but still do exist, patients with sickle cell disease, usually effectively lose their spleen by about age 5 or 6. And then, so a little bit more about antibodies. You can have, antibodies are what provide your individual immunity. So passive immunity are what you get from maternal antibodies. Active immunity comes either from immunization or from direct exposure. And that, for some things, for example, hepatitis B virus, we can measure whether you actually have the antibody to it by getting a titer. And so that's where you seroconvert, where you actually have the antibody that will work against that. That's called seroconversion, and it's measurable with a titer. So now let's talk about infection control. So the idea with infection control in the pre-hospital setting is that we're trying to interrupt this circle at one of several different places. So we have very little control over the infectious agent, the virulence. We can't affect the dosage that we're exposed to by doing things like using masks, using gloves. We can be aware of the means of transmission, aware of the routes of exposure, and then there are things that we can do to make ourselves less receptive hosts for disease. So this is, as Mark alluded to, this is a training requirement, and it must occur annually. Do you remember how many pages total this was? Yeah. Double. And the whack that, yeah. Right. Multiple. It's over 10. We're boiling it down here. Right. So we're going to talk about the phases of pre-hospital infection control. And then after we'll go through this, and then we'll take a quick break before we get into the specific diseases. So we prepare for response with written procedures, with an infection control plan, the training that you're getting here, the equipment that you need, making sure that your personal wounds are bandaged and treated before you respond to an emergency, using disposable supplies. Part of preparation is making sure that you have a place where you can at least foam off before you're dealing with foam, or use alcohol wipe before you're dealing with the patient. To when you have an active infection, to not be delivering patient care. We also are monitoring for compliance with vaccination and diagnostic tests. Your agency will have a designated infectious control officer. I think we've successfully identified the jobs and processes where the possibility of exposure exists, and then you get hazmat education as well. So in response, what are some issues that you've had in responding to patients who have infectious disease? What's that? Yeah. So often patients don't know, and so we need to have a high index of suspicion that we might be walking into a place where someone's dealing with an infectious disease. You may get some clues from the notes, but we all know that dispatch information is limited. Was there another question? Okay. So then as you're going into patient contact, isolating body substances, so that can be something that someone has thrown up, wearing your PPE, limiting patient contact to the necessary personnel, using adjuncts for assisted ventilation, and then as before, using disposable items. Properly disposing of your biohazardous waste, especially not doing things where you are handling your mucous membranes in the same areas where you're providing patient care. So I'm not going to ask for a show of hands for this, but just think, how often do you actually wash your hands after every patient contact? And I think this is something that's definitely changed in healthcare. That's something that we will get watched in the hospital, and occasionally there'll be little spies that come in and see how often we wash hands. We're not great at it, and we can do better. And we do know that when we do better, we have fewer transmitted infections from patient to patient, but we also lose fewer sick days for your providers. So this is something that you can do to keep you healthy, keep your family healthy. So you're going to place infectious waste in leak-proof bags, decontaminate the contaminant clothing and equipment, and deal with your uniforms as per policy. So when you're dealing with someone who has an infectious disease, and we'll talk about specific diseases and specific decontamination risks that you should be concerned about. So routine disinfection would not destroy Mycobacterium tuberculosis, which causes TB. So intermediate level disinfection using bleach